I'm Dr. G, and welcome back to Diabetic Foot Files. Today, we're going to be diving into complication of chronic wounds, and it's called Marjolin ulcer. And I'm just going to spell it out because it's a French term, and I didn't take any French, but Marjolin ulcer. So Marjolin ulcer is not a typical ulcer, and forgive me for anybody if I'm pronouncing it wrong, but I know it's a French, and yeah, that's the best I could do with pronunciation with that one for now. So, Marjolin ulcer is not your typical ulcer. It's a form of squamous cell carcinoma that arises in chronically damaged skin. So, it can happen in diabetic patients with chronic foot ulcers, and recognizing it and managing it, this type of transformation can mean the difference between limb salvage or, worse, unfortunately. So that's the whole point. This is educational. This is not for self-treatment. So what is a Marjolin ulcer? So a Marjolin ulcer is a malignant tumor, and most commonly a squamous cell carcinoma, and that arises from previously injured, scarred, or chronically inflamed skin. It is aggressive, it's prone to local invasion and lymphatic spread if untreated, most often seen in burn scars, but also in chronic ulcers, osteomyelitis tracts, pressure sores, and long-standing wounds. In diabetic foot disease, any long-standing non-healing wound is a potential risk environment for malignant change over time. So let's get a little bit about the history of the name because doctors used to name their discoveries after them. So it was named after Jean Nicolas Marjolin, and who in 1828 described a malignant change in burn scars. Later studies clarified that it was not a new ulcer, but a squamous cell carcinoma arising from scar tissue. And the concept extended to other chronic wounds as clinicians observed similar transformations. So, what is the pathophysiology behind Marjolin ulcers? So, chronic inflammation. So, chronic inflammation that will lead to DNA damage. So, this persistent inflammation causes ongoing cell turnover, free radical generation, and DNA replication errors. Then the cytokines such as TNF alpha, IL-6, reactive oxygen species, and enzymes like MMP can create a mutagenic environment. So they mutate. Okay. So also with the impaired healing in diabetes, diabetic wounds already suffer from impaired angiogenesis, neuropathy, ischemia, and immune dysfunction. And this chronic insult favors cell dysplasia over time, and it drives a pre-cancerous change. So, scar tissue has an altered extracellular matrix and also has a reduced vascularity. So, it also has reduced immune surveillance, and that would enable malignant cells to thrive. So, what are some of the key steps for this type of malignant transformation? Persistent wound stimulation, accumulation of DNA mutations, evasion of apoptosis, clonal expansion of dysplastic keratinocytes, and invasion and metastasis. So, when it comes to the histopathology of it, classic findings on a biopsy, because if it's not healing, you should biopsy it, okay? You get to a point where you might have to biopsy it. And I told you about the pyoderma granuloma, my attending, she trained me very well, but this is before residency. She they had a leg ulcer that wasn't healing. I just thought it was a venous stasis ulcer, but then she did a biopsy and it came back as pyoderma granuloma. So that's a good example of that. But I was impressed by her clinical thinking and she just knew all the steps to do. But let me continue. So classic findings of a biopsy for Marjolin ulcers, malignant squamous cells. They form nests and islands. Then there will be keratin pearls. These are like layers of keratinized cells. Then you will have something called atypia. So atypia, because it sounds like atypical, right? It's a regular nuclei, high nuclear to cytoplasm ratio. And then invasion into the dermis and deeper tissues. So, what are some of the biochemical markers? So, there would be an increased expression of P53 mutation, so tumor suppressive gene loss. There would be EGFR upregulation, and then cyclin D1. Cyclin D1 actually promotes cell cycle progression. And so, this chronic inflammation elevates the cytokines, promoting tumorigenesis. So, how do you recognize it clinically? So, signs that a chronic diabetic wound may be transforming into a Marjolin ulcer is change in appearance. So, from a flat ulcer to a growing hypertrophic margins. What about a rolled, everted edges? Increased granulation that looks more exuberant or friable, unexplained bleeding, pain that is disproportionate or new, non-healing or expansion despite optimal care, and lymphadenectomy. So let's say enlarged lymph nodes nearby. So what are some of the red flags? Red flags are sudden size increase, vegetative growth, so it's like stagnant, fully stagnant, and a malodorous discharge, secondary of the necrotic tissue. So, for assessment, always consider a deep surgical biopsy of suspicious areas. Avoid superficial samples, okay? And this may be deeper malignant cells, okay? So keep that in mind. So, like I said, why can a diabetic foot ulcer can become a marginal ulcer? Diabetes kind of creates that perfect storm. So the neuropathy, the patient doesn't notice the trauma, the ischemia, the poor blood flow, and the hypoxia, the immune dysfunction that causes reduced pathogen clearance, the hyperglycemia, which causes glycation end products, which will result in DNA damage and oxidative stress. And then the wound would probably be in a chronic non-healing state. So a diabetic foot ulcer that persists for months or years encourages chronic inflammation. Remember we talked about diabetic foot ulcer of the 4 stages of wound healing. It's usually stuck in that chronic inflammatory stage, okay? And this setting is makes it very ripe for neoplastic transition. So what is the treatment for Marjolin ulcer? So early detection, refer to oncology, okay? Refer to the specialist and surgical specialist, okay? But oncology. Imaging, MRI or CT to assess the depth and spread. Usually they will do a wide surgical excision with clear margins. They might do, most likely they will do a sentinel lymph node biopsy to see if any metastasis is suspected, and then adjunct radiation therapy in select cases. So, like I said, surgical options most likely will be for the doctor, the oncologist, the surgical oncologist to do a wide local excision, remove the tumor, and clean margin, so margin of healthy tissue. And for deep invasion, possible amputation, most likely, or below the knee amputation if necessary, because you have to remember there's not just ulcer now, this is actually a tumorous ulcer. And that's because it transforms into that, okay? And these are in very particular selective rare cases, but it's good to know about all the possibilities, okay? And sometimes they can do reconstructions with flaps or grafts when possible. And post-op is you have to have close follow-up for recurrence, like they always do for any type of oncology, lymph node surveillance, and optimize your diabetes control and vascular status. So, what does the latest research say about Marjolin ulcers? We talked about the molecular markers as targets for early therapy, so P53, EGFR inhibitors, immunotherapy for advanced cutaneous squamous cell carcinoma, as we turn into the age of AI, they have AI imaging tools to identify dysplastic changes in the wound bed sooner, which will be fantastic and amazing. And I want one too. And research focusing on the biomarkers in wound exudate. Isn't that fantastic and super interesting to identify early malignant transformation? and also genomic profiling of chronic wounds to predict malignancy potential. So, this was a quick little summary of Marjolin ulcers, but it reminds us that a chronic wound aren't just slow to heal, they can actually turn and transform into something, unfortunately, that could be deadly. So, as clinicians and caregivers, it's key to be vigilant and early recognition, keep with knowledge, monitoring timely intervention actually is the biggest thing that saves limbs and lives. And if you're treating a long-standing ulcer, especially if with diabetic patient, always keep an eye out for signs of anything that you might see suspicious. You make sure you cover all your bases, not to scare your patient or anybody. Don't be scared, okay? But like we said, early intervention makes a huge difference. And I hope everybody loved this episode of Diabetic Foot Files. And take care of your feet because they take care of you. I'm Dr. G, and have a great day.